So I'm going to talk about the prevalence of HIV-associated neurocognitive disorder in a high-functioning and optimally treated Australian cohort, and what are the implications for international neuroHIV research. So this is a collaborative work, and between some of my students, some of the staff at St. Vincent's Hospital, and also specifically Professor Bob Heaton, that I want to thank for his input into the study because the data are quite complicated. Here I just put a slide for you to briefly look at, which represent the hand criteria as we have them standardized nowadays. And basically they're not very they're actually not different from what we did in the past. They're just more standardized in terms of the cognitive impairment. So there's a spectrum of disease. The spectrum of disease goes from mild to very severe, and there's different level of interference with everyday functioning. So if you can just look at the nomenclature on the left, because I'm going to use it again. So the background of the study, we wanted to know if our Australian population, which is characterized by mostly high-functioning men who have sex with men, so by high-functioning, I mean people who have high cognitive premorbid functioning, perform similarly to American people when we put them on American norms. So the reason for that is because, like many other English countries, Australia use US or American normative data. So neuropsychological normative data are data that are collected in large sample, which represent normative performance. So those people don't have any neurological or psychiatric disorders. Usually they represent a large section of the population. In the US, this population is actually based on the census. And so on this data, we're able to detect the effect of education, age, and sex, and for the US, actually ethnicity. So we wanted to know empirically whether those American data were going to work in our sample. So more specifically, the aims were to determine the rate of neuropsychological impairment in Australian HIV negative versus those who were HIV positive. First using the US normative data, which I'm going to refer to now as US norms. And we wanted also to compare the HIV effect on neuropsychological impairment generating from the US norms versus from norms generated on the HIV negative. So I'm going to call that Australian local norms. And then we wanted to check whether we use those norms, either the Australian or the American, whether we were going to find different association with clinical markers. So the cohort. So we have a patient group of 90 people in their mid-50s. And I think what you have to retain is that those people perform almost one standard deviation above the average in terms of their verbal IQ compared to the Australian population. So that's the WAIS 3 verbal IQ that you see there. So again, showing that they're high functioning, and this is not different between the positive and the negative, of course. And it's a male cohort. I think it's important to remember it's a male cohort only, which has its own limitations. So in terms of the HIV infection, a chronically infected cohort, which is very well recovered and very well controlled. In terms of the neuropsychological battery, we use standard tests that are in use as a battery around the world, initially developed at the HIV Neurobureau Research Center in San Diego, assessing 7 cognitive domain and 11 individual neuropsychological measures. So the first thing was to put the raw score, so when people come and do some tests, they obtain a score, and we can transform that into a standard score. When we use American data, we transform that into American scores, and those scores are corrected for age, education, gender, ethnicity. So in this case, Caucasian ethnicity. And we obtain a score that envelopes those type of correction, but you have to understand that the correction that are encompassed in those scores are American correction, they're not Australian. Then what we did, we developed our own local Australian norm. Even if it's a small sample, it was still possible to do that. And I show here that the data were normally distributed, which is a requirement to develop norms. So we simply put the Australian, we standardize the score of the Australian, and then in the negative, and then apply them to the positive. And then the other thing that we did to develop the global deficit score, so each of those standard score, then are rated in terms of the level of impairment, so either normal, or they go from very mild to very severe. and then for each of those 11 measures that I mentioned before, and then we average those and we create the global deficit score. The global deficit score compared to some other score has an advantage because it works well with the intercorrelation that is within the score, so it doesn't over-classify impairment. So here, what I show is that I show the evidence that the negative Australian sample perform above the American norm. And it is not what's interesting is that it is not statistically significant. So when we don't use the correction at all, we see a negative effect of education and of age and positive effect of education. And then when we use the American norm, there's an overcorrection because those people are overperforming on the norms. Okay? And so this small effect in terms of statistical effect are actually a huge impact on the prevalence that we can detect. So when we use the US norms here on the left-hand side, when we use the US norm, we're able to detect about 18% of global impairment in the positive. When we use the local norm, this jumped to almost 58%. So you see the use of norm here has a huge impact on what we're able to say about impairment. On the right-hand side, I've included actually the prevalence data because we had to exclude 15 cases without history of hand, but it doesn't impact the data, so we still find the same, and we find prevalence that are very similar to what we found to what has been found in the charter cohort, in the non-confounded group, and here it's a non-confounded group as well. Those people have been screened for current substance and alcohol use disorder, and so I should say only that on that. So when we look inside the data into the category of hand, what we see again is that when we look at the local norms, we have this pattern of increment between HIV dementia, MND, and INI. And again, the grouping and the prevalence of this, which INI is the most frequent, are very similar to what we found in the charter cohort. To what has been found, to what has been found in the charter cohort, which use the same statistical methodology. Rather than when we use US norms, we do not find that. We find really low level of impairment. So we run the risk of saying to patient when they come to see us, oh, everything is fine with you, when actually not everything is fine. And when we look at the profile of impairment, so that's interesting. It's the standardized mean difference that's plotted here. And what we see that the profile of impairment across the different cognitive function is similar using both the Australian and US norms, but that, of course, the severity of impairment is much more reliably or accurately detecting, we think, using the local norms. And here on this slide, what I show is that when we use the US versus local norms, we found that we are able to detect different type of disease effect. When we use the US norm, we detect an AIDS effect through the AIDS-defining illness, rather than when we use the local norm, we detect a cardiovascular effect. But in fact, this effect is an age effect. And you have to think that the local norms, as much as they improve the detection of impairment, they are not demographically corrected. So there's an age effect embedded. So what we see here is the correlation of age to the neuropsychological performance. What I find interesting is that despite this, with the two sets of norms, we detect something that's very important to diagnose hand in the heart era using the antineurotic criteria. We found that the independence of daily living is actually associated with both type of nomenclature. So I think it's interesting. So you could expect that those two populations, US norm versus Australian, especially when you restrict to some subgroup of the population, are going to be fairly similar. But I show that's not the case, and we have to be very careful the way we interpret neuropsychological data. So after all of this, Bob and I, we think that we need to develop norms for Australia. We probably have the resources to do it here, but we have to include premorbid abilities correction in addition to the usual factors. And we think that maybe a more average sample, with a more average sample, people who are not high functioning like that, we would have found the same thing as in the US. But there is actually, I'm doing some work with Bob on that. We're going to try to develop maybe Australian norms. And reviewing the literature, I found that even in average samples, sometimes the US norms simply do not work. It's a complex issue. Anyway, what are the implications for international neuroHIV research? There are quite serious implications, and refer to some of the publications that I've put in the last 2 or 3 years, where I say we have to start to worry about this varying prevalence that people are putting every now and then. It doesn't reflect well on the field. because people are not using appropriate norm for their population. And one of the things that I see as well, people are working without neuropsychologists. You have to work with neuropsychologists because this data is extremely complicated, and it will become more complicated as we start to look in countries where actually there's not much neuropsychological data that's been collected. So I'm talking about low to medium income countries where we know already that it's not only age, education, gender, and sometimes ethnicity that affect the neuropsychological performance. It's some other very complex factors such as rural versus urban residents, the access and the quality of education, some poverty index that have been done in social sciences, and even some very complex interactive effect between education and gender. So what I mean is that if you do not correct for those effects in your non-HIV population, that you are unable to see the HIV effect in your positive people. And so whether you correct or not adequately for your population in those people will dramatically influence your interpretation of your neuropsychological data. So again, I guess the take-home message on this, if you want to run research in this area, just find a neuropsychologist you get on with and try to work out with them, the best way to analyze the data. It is extremely complicated, and as I said, with increasing internationalization of this research, this will become increasingly complicated. And yet, when I contacted Bob for this paper, we still find a solution to analyze the data, I think, in the most optimal way, and find a prevalence rate that are very similar to the Charter cohort. Thank you for your attention.
Questions?
Thank you for the funding bodies and the participant, of course.
Yep,
questions?
Thank you.
Thank you for the presentation. Artis Mo from UCLA. I may have missed a slide. Did you collect any data on active hepatitis C or things like amphetamine or cocaine use?
Well, so as I said, this cohort was screened for current substance use within the past 12 months of the study entry. And in Australia, hepatitis C infection is very actively treated. So we had 3 people who had Hep C, but they had been successfully treated. So basically, the level of HCV RNA was below detection. So it's not too much of an issue in that particular cohort. So I guess one thing I should say here is that the main limitation of the cohort is that we really screen for those sort of elite sort of type of HIV people who are doing relatively well. Although it's a middle-aged cohort, I should have said that. So with all of that, you have to take that there's some relative truth to what we've said. But I think it's interesting that despite the difference with the US, that we end up finding very similar prevalence rate to the Charter cohort. And I think it really contradicts some finding that I see there's no HIV effect in some other population, which are very similar to ours, in particular in the UK.
Okay, thank you.
Yeah.